Welcome to Enroute, the podcast of the First Responder Behavioral Health Institute. The First Responder Behavioral Health Institute is bringing together some of the most inspiring and dedicated change agents in the global public safety, psychotherapy, and educational communities. Each episode of Enroute seeks to bring together first responder change agents and clinicians dedicated to constructively disrupting the status quo by tackling the tough subjects like first responder suicide, post-traumatic stress, moral injury, sanctuary trauma, leadership development, critical incident response, peer support teams, and what it means to be psychologically safe and healthy while working in an unsafe world. All units, please stand by. The Enroute podcast is about to begin. You can resume normal traffic on this channel after this transmission. I'm Joseph Brigandi. Thank you for watching Enroute. Today, we bring you Dr. Roger Solomon, a psychologist and psychotherapist specializing in the area of trauma and grief. He's on the senior faculty of the EMDR Institute and provides basic and advanced EMDR training internationally. He currently consults with the U.S. Senate, the National Aeronautics and Space Administration, and several law enforcement agencies. Dr. Solomon has provided clinical services and training to the FBI, the Secret Service, the U.S. State Department, Alcohol, Tobacco, and Firearms, the U.S. Department of Justice, and numerous state and local law enforcement organizations. Internationally, he consults with the Italian State Police. Moreover, Dr. Solomon has planned critical incident programs and provided training and peer support for teams all over the world, and has provided direct services following such tragedies as Hurricane Katrina, the September 11th terrorist attacks, the loss of the Space Shuttle Columbia, and the Oklahoma City bombings. Dr. Solomon has expertise in complex trauma and collaborates with clinicians on the utilization of EMDR as informed by clinical understandings on the structural dissociation of the personality. Roger has authored over 42 articles and numerous book chapters pertaining to grief, trauma, complex trauma, and dissociation. Please join me in welcoming Roger Solomon to Enroute. Pleasure to have you here with us today. Welcome.
Thank you, Joseph.
Tell us a little bit about yourself and your background. Most of the people who are in complex trauma medicine know who you are. Many of our first responders don't. So let us know a little bit about your background and what you do.
All right. Well, I'm a clinical psychologist. I specialize in trauma and grief, and also have extensive experience and expertise working with first responders. My first full-time job was working as a psychologist, a police psychologist with Colorado Springs Police Department. And that was 1979 to 1988. And then I became the department psychologist with the Washington State Patrol and did that for 6 years. And then continued to work with first responders, military, with veterans, and a number of federal law enforcement organizations, FBI, Secret Service, ATF, NASA, Department of Justice. And currently, I am a part-time contract employee with the United States Senate, providing EMDR as an assessment and referral tool. And I'm working with the internal Employee Assistance Program of the United States Senate.
Now, you've been a member of EMDR community for a long time and a longtime friend of Francine Shapiro. Tell us a little bit about that time, what actually EMDR is and how we would utilize it. A lot of my first responders are a little leery of it. I do a lot of debriefings myself, and one of the things I'll hear from them is, that's some voodoo stuff you're talking about right there. So can you take the voodoo out of it and explain EMDR for us?
Yes, many people call it that, the voodoo stuff.
Yeah.
So, yes, it is something that can look mysterious, all right, because it involves thinking of the critical incident. And usually we do some type of bilateral stimulation, which can be eye movement or can be tapping. And yes, it can certainly something that can look a little hokey. What is this stuff? So let me explain it. That we have an information processing system in our brain. And when something negative happens, we can think about it, talk about it, mull it over, read a book on it, sleep on it, dream on it, etc. And it becomes processed. It becomes integrated. It's something that happened and not happening now. It goes to the past. But something that is particularly distressing can get stuck. It can get frozen in the brain, stuck in the brain, unable to fully process. And when there's some kind of reminder, up it comes. The images, thoughts, emotions, sensations, the movements, the fear, the franticness, the state of mind, the sense of self that one had at the time of the trauma gets evoked. So in this way, the past is present. So present problems are the result of past experiences that are not fully processed. Well, EMDR therapy, originating with Francine Shapiro in 1987, who just stumbled upon it, put together the framework, is a therapeutic framework that research has shown, I think at this point, or probably around 80 studies have shown its efficacy. Now, what it does, it's a lot more complicated than it looks. It's not just eye movement. There's so much more. What we do is we'll access that memory. Think about the images, negative beliefs, emotions, sensations. And then the eye movement does seem to give a jump start to the brain's information processing mechanisms, which may be like REM sleep when we're dreaming. Other research has shown it's similar to slow wave sleep. In other words, slow wave sleep, it would push the trauma through the brain. So that now, instead of being something that's too much and frozen in the brain, is now integrated into the regular memory network. In other words, it goes from here in your face to back here. Something that happened, it's not happening now, but you still retain appropriate emotions and survival information. So again, it is something that is it's particularly useful for people who don't like to do a lot of talking. You do have to be able to stay present and articulate what's happening, but a person does not have to describe a lot of detail in EMDR therapy. And as I said before, it is something that is effective for trauma.
People get confused on that. And one of the things they don't understand is we're going from the amygdala back into the frontal lobe, that it's actually affecting brain science, that there's so much research that goes into this. Being an EMDR certified therapist myself, I've seen the benefits that people get right away from it and the relief. And one of the things that you mentioned, which I think is so important, which is why the title of Bessel van der Kolk's book, The Body Keeps the Score, was such a brilliant title in 5 words, because it is in the smell, it's in the cologne of the individual who assaulted the person, and they smell a similar cologne, and all of a sudden they're right back to that state. It's into the backfire that sounded like gunfire back on a crime scene or in a war zone that takes them back to that state. And now they're unable to go ahead and work with it and process it, where EMDR provides that avenue for them to access that. and to go ahead and work through those emotions, and to go ahead and recognize that they can be present with it, and to take it into another place in the brain and another place in their life that facilitates healing. But yep, most of my law enforcement personnel call it the voodoo cure.
Yes.
And I love that. And I thank you very much for explaining it to us. You do this work all over the world. And, that's one of the things. I've attended your classes in person and have had the privilege of your mentorship over the years. And to watch some of the work that you've done is just inspiring, and it continues to do that for me. You've spent quite a little bit of time in the Ukraine training their therapists. Tell us a little bit about that journey and what it's like.
Well, I was working in Ukraine before the war. Actually, the first time was in 1994, and went over to do EMDR training in Kiev. And I went back a couple times that year. Went back in 2016 to give a lecture, to work with military psychologists. And remember, the war started with 2014, and I started doing EMDR therapy training, 2020, June of 2020, and then of course there was the invasion last year in February. So I have continued to do training online. Also, I've done sessions online, working with clinicians who have their own traumatic experiences. I've also been working with families of soldiers killed in the line of duty. And I've been providing training to clinicians, not only in EMDR therapy, but in complex trauma and dissociation, and also dealing with grief and mourning issues. I went live this last April, 2023, and before in 2022, and I look forward to going back next May, 2024.
You've done an awful lot of work in the area of grief therapy. One of the programs that you run is the EMDR and the Art of Grief. You were featured in the Handbook of Grief Therapy, the utilization of EMDR therapy with grief and mourning. Tell us a little bit about that chapter and more about grief and mourning and its use in EMDR.
Yes, and let me give it to you in a nutshell.
Okay.
When we lose somebody, certainly it's a trauma in and of itself. The person is gone, they're not coming back. So EMDR therapy can be helpful in several regards. First of all, it can help with the trauma of the loss. And secondly, what emerges with EMDR therapy, as with any successful therapy, is the emergence of positive, heartfelt, meaningful moments. So most frameworks on grief and mourning talk about how it's important to remember our loved one. And when we do, we feel the joy, we feel the love. However, there can be a lot of pain. It can be too much to fully realize that the person that we love died and is not coming back. So EMDR therapy, we can work with the trauma of the loss. And yes, it's painful. This emotional realization is painful. But in going through that, it gives access to these positive, adaptive, meaningful memories that are heartfelt. And a person starts to form what's called an adaptive inner representation of the loved one, with the goal being they can think of their loved one, have these positive memories and moments, and it's felt in the heart. So This leads to a greater sense of positive connection, going from a connection of pain to a connection of love.
Yeah. Yeah. I've had many people stuck in pain, unable to process that because they feel like if I process through the pain, then I'm going to go ahead and my loved one will just be a memory, instead of recognizing that as you process through the pain, you'll also get those wonderful memories back of that time spent together.
Yes, very important principle. Some people are afraid to lose the pain out of fear they'll lose the connection. It's just the opposite. If we're able to reprocess that pain, they have more access to the positive memories, meaningful moments, and a greater sense of connection.
Nice. One of the things I had wanted to learn and study as a first responder was post-traumatic stress and stress-related disorders. And I thought that if I understood that, I'd be at the pinnacle and the top of my game, and I would be able to help our first responders and reduce suicidality. When I started this journey, I met you about halfway there, and I started to realize that post-traumatic stress is a plateau, and then we enter a world called traumatic-related disassociation. And I realized, oh my goodness, that's the top of the mountain up there. What is traumatic-related disassociation, and how do we work with that?
So, complex trauma or trauma-related dissociation is what happens when there are severe events, especially in childhood, that are too much, abuse and neglect. Let me explain it this way. Everything with us human beings, any living being, is geared toward survival. And if something happens that's too much, an experience occurs that's too much or it's too overwhelming, well, that memory gets stuck in the brain, unable to fully process. But if there's a lot of trauma and it's severe early in childhood, especially from a caregiver, then how do we survive that? Well, there's a division of the personality. And one or more parts of the personality are engaged in everyday living, self-care, work, socialization, etc. And there'll be one or more parts of the personality holding the trauma, reenacting, re-experiencing the trauma. So now we can think of a continuum. We can even think of simple post-traumatic stress disorder as one part of the personality engaging in everyday living. And there's a part of the personality that holding the traumatic event, re-experiencing, reenacting it, not knowing it's over. And when there's a trigger, a person re-experiences the event, the emotions, physiological arousal, okay? And of course, the more severe and earlier the trauma, the more there can be this division in the personality. So we can think of it as a continuum. So what's important here, especially for first responders to understand, that if there's a critical incident, one, it can be traumatic in and of itself, but it could start to bring up earlier unresolved trauma, losses, and particularly these childhood experiences involving our caregivers. These memories get maladaptively stored in the brain and they get triggered. And as a result of that, there's difficulty in dealing with emotions, difficulty in relationships, and again, there are also self-esteem problems.
Yeah. Now, our first responders have a lot of fear about stigma when it comes to mental health issues and seeking help at work. And they feel that they're going to be targeted for removal, or that the leadership doesn't understand that most trauma can be dealt with and that they can return to work. That is one thing that I've spent a great deal of time trying to work with administrators to understand, is that when we have a firefighter, say, who's fallen off a ladder and broken their leg in 3 places, we have physical therapy, occupational therapy, return to work protocols and policies, and it's our objective to get them back on the job and to take care of them. If somebody is struggling with a critical incident they've experienced or needs time to maybe go to the Center for Excellence for the International Firefighters Association for Recovery, there's often a sense of stigma, and administrators don't understand that these individuals can return to work. One of our faculty members, Mark Bouchard, is a wellness officer with the RCMP, and he wrote Setting Your Sights on Stigma, Thoughts from an Injured Mind. A SWAT team operative and still on a SWAT team today, but there was a time within his agency that he had to educate them to the fact that, hey, this is a recoverable injury in many instances. And, leaders don't have the training perhaps or the knowledge to understand that. What words do you have for our administrators and public safety organizations when it comes to treating their members and understanding post-traumatic stress?
Well, I agree with you 100%, Joseph, that first of all, we are looking at something that is treatable, that we can do something with. And not only that, when we work through our critical incident, we emerge stronger. We become more resilient. After facing our own vulnerability, our own fear, and getting through the other end, we are going to emerge with better coping skills, better understanding of ourselves, better equipped to deal with future critical incidents. So the thing is, stigma can prevent a lot of first responders from getting the support that they need. So that's why the services need to be confidential. And the job of the administration is to provide these programs. And again, it's got to be with culturally attuned therapists who understand first responder culture. And another very important part of the administrative duties in this program is to stay out. It's confidential. It is something provided to support their employees who go through a traumatic incident. Joseph, I've been around for a while, and remember the early days and involved in current circumstances. We would lose a lot of officers involved in a shooting, not so much because of the trauma, but because of the way they were treated. So they might recover from their trauma, but it can be very difficult to go back and again face a stigma and have to worry about how they're going to be treated by the organization. There needs to be support, and this includes peer support and professional support as needed that is separate from any administrative process. And I'll tell you, Joseph, I think first responder agencies have come a long way in this regard. Certainly there used to be a significant stigma. It certainly was when I first started. But I've really seen it come a long way. I think most first responders and administrators understand the need for support when there is a traumatic incident and do provide it. But yes, I think it's difficult for anybody to want to deal with events and with emotions that were so powerful, it got frozen in the brain and isn't going away. And again, I want to emphasize there are programs, there are therapeutic methodologies that can really be helpful. You don't have to live with these images in your face. We can take care of that most of the time. I do want to say this, Joseph, getting back to trauma-related dissociation or just complex trauma, that there can be a critical incident that occurs and it starts bringing up the other past material. We can deal with both, and EMDR therapy is helpful, not only with the current trauma that someone may have experienced, it's also helpful with past traumas as well.
I agree. I couldn't agree more. And one of the things you said that resonates so much is the role of peer support. Many of these people that I've worked with, my clients, have gone from facing a traumatic-related incident, being targeted for removal, and have often come back into the agency to be peer support folks that are highly effective because they have a lived experience here. They're able to go ahead and speak to the membership in a way that they can relate to. And one of the other things that we need to go ahead and start doing with peer support is to add clinicians to it. I offer a clinically directed peer support course, and it's a challenge in that, number one, how do we get culturally competent clinicians into those roles? The other thing is the understanding that administration can and needs to stay out of it. I assure my peer support teams when I meet with them and visit with them that this is not going back to HR. This is not going back to your administration. I am here 100% for you and to go ahead and make sure that you get competent and quality services. And not necessarily with me or my agency. I come armed with a list of a dozen great people in the DFW area that have spent the extra time, tried to learn this culture, and are available to you. But there's a resistance into accepting that and a big fear. So educating administrators, another reason we do leadership development courses, is to go ahead and educate them as to what their role is. And as you said earlier, your role is to stay out and to be supportive and to go ahead and recognize that this is a healing process, a recoverable process. And it'll be a good thing the day that we have smashed the stigma, so to speak, to the point where this is not going to be looked at any different than having broken an arm or a leg on the job. And we're just looking forward to getting you back into service and getting you the care you need.
That's right.
Now, you've been doing an awful lot of work all over the world. I believe today we're meeting you in Finland. What are some of the next events that you're on your way to go ahead and present at?
Well, a lot of my programs, the core is EMDR therapy, okay. And the context is grief and mourning, complex trauma, and I also work with first responder agencies, and I also train clinicians in EMDR, clinicians who will be using EMDR therapy with first responders. And in Finland now, I'll be going to Italy and Australia, New Zealand, Singapore, Bali, Taiwan, and there's Brazil's going to be a webinar. Okay. I'm looking forward to at some point going live there as well. So
very nice. And the First Responder Behavioral Health Institute is planning to bring you to the Dallas-Fort Worth area March of 2024 for a 3-day event, training peer support teams, and 1 day of working with clinicians in the area of traumatic-related dissociation. In the 3-day peer support training, what would some of our peer support teams learn by attending this class with you?
Well, let's understand what peer support is. There's so many different levels. And the workshop that we're going to be doing together, Joseph, is to help train peers to be present, normalize other people's experience, and be able to share their own. So let's look at this as an introduction. Here's my philosophy. It's one thing for me, a psychologist. I have a PhD. I can tell you flashbacks and nightmares are normal reactions to an intense situation. But it's another thing for a peer, someone who's been there, to come up to you and say, you know what, after my incident, I had nightmares, I had flashbacks, and I'm not nuts. And if you're experiencing some of these reactions, you're not nuts either. So, peer support in this course that we're envisioning, and this is a model I've used for years, for decades. I used for police, fire, military, therapist. I also work with railroaders. I'm very proud to have been working with Via Rail Canada since may have been 1991. A lot of work also Union Pacific Railroad. So what the workshop will be, first of all, we're going to provide education on critical incident trauma. And the best way to learn about what critical incident trauma is for first responders is to talk with each other. Nobody's ever forced to talk, but so much is learned for when everybody tells their personal story. And it's also helpful to have some practice among your peers to tell your story, because somebody may need to hear it. So, and what we ask is for people be themselves. We don't want to train people to be counselors. That's not a peer. It's being yourself, listening in a non-judgmental manner. It's understanding, and it's normalizing. Now, that's an important part of peer support. And first responders already have a high level because they do it every day with the public. Now, a second aspect of this workshop is going to be to promote personal healing and resilience. That's the way I think of this workshop. I think of it as promoting the healing of trauma and enhancing resilience. One's ability to bounce back, one's ability to come out stronger and utilize the wisdom gained from going through a critical incident to further your ability to deal with other life challenges. So, now, EMDR will also be offered on a volunteer basis. We have found, and there is some research, that EMDR applied to critical incidents within the context of this kind of a 3-day program really is healing and can really integrate that trauma, promote the healing. And we've seen this, and most of the people who come in with a critical incident. Now, at the same time, people may need more support. So a very important part of the workshop is to recognize this as the first step, and that there is further support available as needed. Not just done. And we don't forget about people too. We can certainly provide the follow-up that is needed. But what we want to do is provide a safe environment that's confidential, where you can talk and realize you're not alone, better understand what you've been through, what you're experiencing, and give you the tools on how to cope with it, how to deal with it constructively, and how to support others through a critical incident and their own trauma, come out the other end stronger, more resilient.
I agree. It's an incredibly special opportunity and experience to sit with your peers and to have these experiences and to get the opportunity to see it done. When we had worked together in Maryland just before COVID had hit, and we had planned to roll these kinds of courses out together, the overwhelming love and support in the room was just life-changing for me and for the other participants. And we saw, when you see EMDR done right there, and you get to go ahead and see the voodoo piece removed, and you see the clinical efficacy shown. And the participants, I remember one individual saying, I wasn't able to recall this incident clearly and articulate it fully to internal affairs when they had asked me to give a statement. And now here today with you, I'm in touch with all of the memories. It's not hurting me. I'm very clear in what I saw and what went down. And, he had reported that it was the best sleep he had had. We had him, I think, the 3-day workshop, and you had done this particular processing on day 1, and on day 2, he had reported some of the best sleep he had had since the trauma he had faced. Life-changing work right there.
Mm-hmm. Mm-hmm.
Now, we also have a Saturday planned for clinicians. Can you give a little voice to what some of that training is going to look like on Saturday?
Yes. Well, it's important that clinicians be knowledgeable about complex trauma and trauma-related dissociation, and just have a framework that can inform their thinking of understanding how it formed, what happened, and to have and to learn treatment methodologies, and that would promote healing. For example, what's important is to do what's called phase-oriented treatment. The first phase of treatment would be stabilization. When we're working with people where there's been a lifetime, a childhood that's too much, you can't just jump into the memory. It could be re-traumatizing. So we'll do stabilization, psychosocial education, help with daily living to increase their window of tolerance, the ability to stay present with intense emotions. That's putting it simply. Then we can move into doing the memory work.
Nice.
And then doing the memory work, it frees the third phase of phase-oriented treatment is personality reintegration. Personality reintegration and rehabilitation. Because now the person can learn new skills, they relate to the world, other people, and themselves differently. But of course, there are other triggers as well. And let's understand these 3 phases. It's a spiral. You'll start doing stabilization. Now you do some memory work, but that starts triggering more distress. So back to doing some calming, relaxation, back to memory work. Now the person's ready to try something new, and maybe that's successful, but it also starts bringing up some other distress. Maybe we need to do more stabilization, more memory work. So these 3 phases of stabilization, memory work, personality reintegration, think of it not as linear, but as a spiral, circling back as needed. And there's a lot of tools and methodologies within these 3 phases.
Excellent.
And of course, yes, EMDR therapy is very consistent with each of these phases.
Now, you have to have completed EMDR's level 1 and 2 to attend this workshop and be a licensed clinician, yes?
Well, no, it's okay for non-EMDR clinicians to come.
Okay.
So, because I can still talk about what dissociation is and treatment phases, and I can certainly talk about EMDR and talk about EMDR treatment and show case examples on videotape.
Okay.
So it may be that other clinicians would be curious and then afterwards go get the training, but I certainly hope to be able to teach the clinical phenomena and philosophy of treatment and give some nuts and bolts methodologies.
Excellent. Excellent. Now, you are popular all over the world, and following you and your journey on Facebook is inspiring. One of the places you're most loved is Italy. You have a book out there. You help the Italian State Police on a regular basis, and I understand that that book is in the process of being translated into English. Tell us a little bit more about it and when we might be able to expect it on shelves here in the U.S.
Yes, well, it's the book is on the EMDR treatment for grief and mourning. Okay. All right, and transforming the connection to the loved one, as I've talked about. So it is out in Italian. It'll be another few months before it's out in English. It is in press with Oxford University Press, and when it comes out too, there's interest here in Finland and other countries in the translation.
Of course there is. Excellent. We've taken a lot of your time today. You've been very gracious with us. As we start to wrap up, what messages do you have for our viewers, first responders in crisis, or in general, that you want to share with our community?
So, first of all, to first responders, and having worked with first responders, again, I've done more than just being a psychologist. I've certainly been an active participant responding to many types of incidents. I want to thank you. I am grateful to you. You are needed, you are important, and even though there's a misguided, misunderstanding public, live with it. Don't take the criticism to heart, because what you're doing is important. You are important. You count. Keep at it. And there are people like you and me. We want to support you. When there is a critical incident, we don't want to just help you get through it. We want to facilitate you coming out the other end stronger with more resilience and capacity. So again, I thank you as a father. I thank you as a grandfather.
Excellent. Very important words for everyone to hear. And if we want to go ahead and get in touch with you to book a program, we can go ahead and have them reach out to the First Responder Behavioral Health Institute, and we'll go ahead and get them in touch with you to go ahead and get a hold of your classes and programs. It's an honor and a privilege to have you on the show today, to have you as a member of our faculty and our advisory board. So on behalf of the Institute itself and from the bottom of my heart, Roger, I can't thank you enough for your support of us, and we're honored to support you in return. So thank you.
Oh, and thank you, Joseph. Goodbye. We'll talk to you later.
Sure will. Thank you. I'm Joseph Brigandi. Thank you for joining us for this episode of Enroute. Enroute is a production of the First Responder Behavioral Health Institute. To learn more about us, head on over to FRBHI.